Good evening. Welcome to the Guts Instincts, an IBD education webinar for the Black African American community. I am Dr. Lejeune Lockett, a faculty member at Charles R. Drew University of Medicine and Science, as well as Crohn's and Colitis Foundation Chapter Board member. We are extremely excited to be with you this evening and host this program. The Crohn's and Colitis Foundation is committed to advancing the efforts of diversity and inclusion within the internal and external scope of the organization. Through education, support, and advocacy, the organization is invested in ensuring diverse communities receive the latest IBD information and resources tailored to each population's need. This program is one of many events we will host for communities of color. We have a wonderful agenda planned for you this evening, which includes 3 presentations. After the presentations, we will have a question and answer session in which you will have an opportunity to ask questions of our guest speakers by typing them into the question box. Please note that all attendees will remain muted throughout the webinar. Before we introduce our first speaker, I would like to thank our sponsor, Genentech. Thank you for supporting the webinar and the foundation. At this time, I would like to introduce our first speaker, Dr. Paula Adamson. Dr. Adamson is an assistant professor of medicine in the Gastroenterology department at Morehouse School of Medicine. She attended the University of Toledo for her Doctor of Medicine degree, the Southern Illinois University for her postgraduate degree. Her research interest is inflammatory bowel disease. Dr. Adamson will be presenting on Back to the Basics, what you need to know about IBD. Thank you for joining us tonight, Dr. Adamson. Over to you.
Hello, everyone, and good evening. Thank you all for participating with us this evening. And I'd like to thank the Crohn's and Colitis Foundation for inviting me to participate in this evening event as well. So as mentioned, I'm going to talk to you about breaking down the basics of adult IBD. I have no relevant disclosures. And so today I'll talk to you first. We'll define IBD. We'll talk about its potential causes and diagnosis. We'll discuss briefly the management and treatment because we'll have a more thorough discussion in our next presentation this evening as well. We'll talk about our highlights in special populations, and then we'll briefly discuss the role of diet, nutrition, and complementary therapies in the management of IBD. So first, what are inflammatory bowel diseases? And so inflammatory bowel diseases are disorders that cause chronic inflammation throughout the gastrointestinal tract. Crohn's disease and ulcerative colitis are 2 forms of IBD, and the symptoms that patients can present with in the course of the disease can vary depending on the severity as well as the location of the inflammation. There are lots of potential factors to consider as far as the presentation and contributing factors for how patients may present with their IBD symptoms. There are genetic factors, environmental exposures, gut microbiota may also play a part, and we'll talk about some of these things a little bit more specific as we go through the presentation this evening. So as I mentioned, some risk factors, race, I think it's important to highlight because previously this was thought of as a disease that predominantly affected Caucasian patients. However, it's very clear now that it can obviously impact any race, and more importantly, we're seeing more or increasing numbers within minority patient populations, which is one of the driving factors for some of the information sessions like this. Family history, obviously, if you have you are said to be at higher risk if you have a close relative, meaning a parent, a sibling, or a child who has IBD, but there are plenty of patients who have IBD who do not have any family history. One important environmental factor that also wanted to highlight is cigarette smoking, because that's obviously something that can, from a patient perspective, is a controllable risk factor, specifically in the development of Crohn's disease. Now, when we look at Crohn's disease and ulcerative colitis, they do have some distinguishing features. First, we can look at ulcerative colitis, and if you look at the darker pink sections, ulcerative colitis typically will start in your rectum, and it will continue. It can either just affect your rectum, or it can continue on to affect parts of your colon. It usually does so in what we call a continuous fashion, meaning that it whatever area it affects, it continues on in kind of a straight pattern. It can affect a small portion, or it can even affect your whole colon. When we talk about Crohn's disease, if you look at the picture here, you can see the dark pink area can be scattered all throughout. It can be in your colon, it can be in your small bowel. Crohn's disease is one that can affect the GI tract anywhere from the mouth all the way down to the anus. And usually when patients present with either Crohn's or ulcerative colitis, it tends to either affect or come on in the early age onset, meaning between like 15 to 35. But then you can also have patients who actually don't have any presenting factors or symptoms of IBD until later on in life, in their late 50s, just all the way up to age 70. As I mentioned before, the symptoms of IBD or either Crohn's or ulcerative colitis varies, again, depending on the location of the inflammation, as well as the severity. But some of the common features or symptoms that patients may have is abdominal pain. You may find that you have diarrhea, perhaps seeing blood in your stools. Patients may also report weight loss, fatigue, and a lot of these things may be multifactorial as some of the symptoms become more severe. Now, many of you, if you've already been diagnosed with IBD, may have gone through some of these exams and tests, but the first step for anything in medicine is usually getting a history and physical examination. But we have several diagnostic tests that patients will probably go through. First, things that most patients will have are blood tests. We want to look at your hemoglobin to see if you're anemic, especially if you've been seeing blood in your stools. You may have had to send over stool studies to look for infections in your stool. There are lots of different radiologic studies like CT scans and MRIs that you may have had or may have somewhat or down in the future. And some of these CT imaging studies are going to be looking for inflammation. They may be looking to see if you have any narrowing anywhere in your colon, which can happen after a long time, long-standing inflammation. And of course, many of you may have or may be getting ready to have an endoscopic procedure like a colonoscopy or a flexible sigmoidoscopy. And this allows us to go in and actually take a look at the mucosa. We can see if there's any inflammation. We can take biopsies, which is a very important feature in not only diagnosing, but throughout the management of your disease course to see how well you're doing on your medical therapy as well. And after we've done all these studies, that can help us, one, say you have IBD. It will also help us distinguish between Crohn's and ulcerative colitis. And if it's not clear, you may have to go undergo some additional studies. Again, some of the symptoms of IBD, especially of IBD flares, which when you go to see your doctor, they're probably commonly ask you some questions about diarrhea. How are your stools? How many stools are you having a day? Are you having urgency? Do you feel like once you have to go to the bathroom, you need to get to the restroom immediately? Are you waking up in the middle of the night to use the restroom? Are you seeing any blood or mucus in your stools? These are all going to be important things to keep in mind. Ask you about abdominal pain or cramping, if you've had any fevers or any fatigue. Those are going to be symptoms that patients can present with. Now, I've mentioned that IBD most notably affects the gastrointestinal tract, but it can also affect other organs and parts of the body. Patients can have, it can affect your bones. Patients may present with arthritis, pain in their joints. They may have pain in their back, which may be related to the IBD as well. Patients can have skin rashes or nodules that can develop. Sometimes you can have some sores that can develop in the mouth, and it can also cause affect your liver, your kidneys, And after long time standing IBD, especially for patients who have been on, if you've had to be on steroids for a long period of time, can affect your bones and put you at risk for developing osteoporosis. So some of the complications of Crohn's disease, as I mentioned, the hallmark of Crohn's disease is causing inflammation throughout your GI tract. And if you've had this inflammation for a long time, sometimes it can cause a stricture, which is a narrowing. And if you look at your colon, you can think of it like a pipe or a tube. If the inflammation causes it to narrow down, things aren't able to get through your stools. And that can cause pain, can even cause obstruction, meaning there's a complete blockage and things aren't able to pass. People can have development of an abscess, which is like a fluid collection that is infected. You can develop a fistula, which is an abnormal connection between two parts of tissue. So you can have a fistula develop between your colon and your bladder. And then, of course, there's always a risk with the long-term inflammation with developing colorectal cancer, which is why if you haven't have had IBD for a long time, you probably have talked to your physician about colon cancer screenings and why you may have to have screening more frequently than someone who does not have a history of IBD. Again, some of these complications, if you're having frequent blood in your stools, with that blood loss, you can develop anemia, which can present with lots of different symptoms depending on how low your blood counts become. You can have fatigue, sometimes maybe the first notable symptom. Dehydration, weight loss. Obviously, when anyone is having a lot of GI upset, they may not feel hungry or have an appetite. But also, if you're having a lot of diarrhea and you're losing lots of volume, that can cause you to present to the hospital with dehydration. So it's going to be very important to be mindful of that if you ever have an IBD flare. As I mentioned before, colorectal cancer, which is where our colon cancer screening test with the colonoscopy is going to be very important. And one of the more severe complications that can develop with ulcerative colitis is something we call toxic megacolon, which is when the inflammation is so severe, it can result in a perforation or a rupture of the bowel, meaning which can be a medical emergency. Now, I'm just going to talk very briefly about some of the IBD management and treatment because we're going to have a much more thorough lecture very shortly after this presentation to go into more details about each of the respective therapies that are currently available for IBD. But once you've been diagnosed with IBD, what our main goals are from that point on is one, to induce remission, meaning to stop, treat the inflammation. And then once we've done that, we'd like for you to maintain that remission, meaning we'd like to keep the inflammation under control. And then from there, it's going to be disease monitoring and prevention. And then obviously the ultimate goal and most important for you as a patient as well is we want to be able to have an improvement in your quality of life. We can definitely understand if you have a flare or if you're having symptoms, having to go to the bathroom very frequently can be very significant on your life as far as going out to eat with family or even being able to work a job. So we definitely understand the complications and the impact that can have on somebody's day-to-day life. So understanding some of the treatment options, there are a variety of things. You have, of course, some over-the-counter medications, which may be prescribed more for symptom control related to perhaps diarrhea, but most of the mainstay of IBD management is going to be prescription medications, and then for severe cases, perhaps surgery may become necessary. So some of the over-the-counter medications that you may have been prescribed include antidiarrheal medications, pain relievers. Some of these include Imodium that patients frequently may take to help slow down the stools, assuming there's no infection. Patients may also, for pain, we generally recommend something like acetaminophen. We strongly encourage or advise patients with IBD not to take NSAIDs because that can worsen inflammation throughout the GI tract. And we also try to discourage any narcotics and things like that because we obviously don't want to promote constipation in someone who already has a GI discomfort or symptoms. Some of the other prescription medications that you may take throughout your lifetime with dealing with IBD. Antibiotics may be necessary. As we mentioned, sometimes people can develop an abscess, which may warrant antibiotic treatment. Sometimes people can have a flare, which is a result of developing a bacterial infection. One of those common things being C. diff. So you may find that you have had to be on antibiotics for that. Some of the patients may have been started on corticosteroids, whether that was during a flare or to induce remission. And some of the therapies include the salicylates, immunomodulators, and there's a lot of biologics and JAK inhibitors, which Dr. Moulton is also going to talk more specifically about each of the drugs within that, in each of those respective categories. Now, if it's been determined that surgery is needed for management of your symptoms, sometimes if we've had longstanding inflammation and you have developed a stricture, medications may not at that point be able to relieve your symptoms, and surgery may be the best course for treatment. And the goal of surgery is obviously to alleviate symptoms and to prevent further complications related to your IBD. And again, with the ultimate goal being to try to overall improve the quality of life for you, the patient. And just briefly for IBD, for special patient populations, it's really important for especially young women with IBD, women that are of childbearing age, to be mindful. Obviously, IBD, it is a chronic condition, but that does not mean that you cannot have a healthy pregnancy. But it's important for you to have an open discussion with your IBD specialist as well as your OBGYN. We strongly recommend that for young women with IBD who are considering being pregnant, that the best thing you can do is to make sure that your IBD is very well controlled before you actually become pregnant. And once you are pregnant, most of the medications that we actually prescribe for IBD are safe during pregnancy as well as while breastfeeding, with the exception of two medications, methotrexate and tofacitinib. When you're pregnant with IBD, like any other pregnant woman, we would recommend a well-balanced diet with vitamins and folic acid supplementation. And again, open communication between both your OBGYN and your gastroenterologist throughout your pregnancy. And next, we'll talk briefly about the role of diet and nutrition in managing IBD. And so in the small intestinal inflammation, there can be, if you have a lot of inflammation there, it may impact how well you digest and absorb your nutrients. With the large intestine, if there's lots of inflammation there, then it also does not perform its job as well, and that can lead to problems with actually absorbing water and electrolytes, which can contribute to dehydration. And lots of IBD symptoms, like I mentioned before, can lead to malnutrition, because if you're having lots of pain and nausea, you may lose your desire to eat. If you're having the severe diarrhea, you can become dehydrated. And if you're having the bleeding, you can have iron deficiencies and anemia. So what are some of the signs you may be malnourished? It's important to note some of these things. If you're under eating or severely restricting a variety of important nutrients, that can lead to malnutrition. If you notice weight loss, or if you notice your clothes are fitting different, or things are starting to feel a lot more loose around the waistline, those are important things to note at home. If you've noticed just a general sense of fatigue or weakness, and then when you follow up with your provider regularly, they may be checking your vitamin and minerals to note any deficiencies there as well. And some things that you can do as a patient to help maintain a healthy nutrition, keeping a journal at home. A lot of patients will mention that they have already identified certain foods that they know bother or irritate their stomach more than others, and being mindful of that and taking a note and eliminating problematic foods in your diet. This can also be done in conjunction with seeing a dietitian or nutritionist who can help you go through different food groups and help tease out what things you should have in your diet or things that you should avoid. And you want to make sure you try to have some small, frequent meals. Stay hydrated, especially if you're having a lot of diarrhea. And then I'll touch briefly on some complementary medicine with, and just want to emphasize that complementary medicine is something that can be done in conjunction with your main medical therapies. This should generally not be used to replace, your medical therapy that's prescribed to induce and maintain your remission. But they can be very important and can definitely help with the quality of life for patients. If that's something that you would like to have as part of your treatment plan. And some of the benefits of complementary medicine can help ease your pain. It can be used to help contribute to better mood and general attitude about you, and helping you feel like you can do something again to have more control about your disease state. And some of the common therapies that patients may do, of course, probiotics, vitamins, minerals, and depending on what your personal interest and comfort is. Now, living well with IBD, some of the important things are going to be being compliant with your medications. That's going to be probably the most important thing that you can do, especially once you've gone into remission. To help maintain remission is going to be very important to be compliant. And it's important for you to understand your disease and what the possible complications are. So I highly encourage you, when you're seeing your provider, to ask questions if there's anything that you're not sure about as far as the disease itself, about your medications, so that you feel empowered about how your treatment care and plan is going. Make sure you schedule and actually present for follow-up appointments, maintain a well-balanced diet, and make sure you establish a support system. Later on in this presentation this evening, we're also going to hear about some resources that are available. There are lots of support groups out there. There's lots of things on Facebook and other avenues where patients are able to communicate with other patients who have similar stories, and may not have someone very close to them that they can talk to about their journey. And most importantly, empower yourself with the information that you receive. And I will be on for questions and answers later on in the presentation. Thank you.
Okay, I was saying thank you, Dr. Paula Adamson. That was a wonderful presentation and very informative. Thank you very much. So our next presenter is Dr. Dedrick Moulton. Dr. Moulton is a pediatric gastroenterologist at the Levine Children's Specialty Center Gastroenterology. He completed his medical degree from the University of South Carolina and his fellowship at St. Louis Children's Hospital. Dr. Moulton currently serves as the chair of the Foundation's National Scientific Advisory Committee Diversity and Inclusion Committee. He will present on understanding Crohn's and colitis medications. Thank you for joining us this evening, Dr. Moulton.
Thank you. Let me get myself together here.
And while everyone's waiting, please feel free to put your questions in the Q&A box that you'll see at the bottom of your screen. And we'll come to questions and answers after the speakers. Thank you.
All right, let's see. So let's talk about this topic of understanding the importance of medications in the treatment of Crohn's disease and ulcerative colitis. And my objective here is actually to talk about inflammatory bowel disease and medications without actually talking a whole lot about specific medicines. And the reason the approach is that way is because I think so often I see that there is an interest in understanding how to select medications and how to have a impactful appointment with your provider. And in looking at the questions so far in the chat, that I've noticed that that stands, so I may be on the right track there. So I have no disclosures. I'll quickly run through my first few slides since Dr. Adamson did such a beautiful job of presenting the basics of IBD. And so we've already talked about this chronic gastrointestinal condition that causes inflammation in the GI tract, with the two types being Crohn's and ulcerative colitis. I'd like to highlight that this is a common condition in the pediatric population, oftentimes forgotten, but I'd like to emphasize that 25% of patients with inflammatory bowel disease are diagnosed during childhood. So this makes it a pediatric condition as well. And along with that, we have the concerns of growth and development that becomes very key to the progress in management of patients with inflammatory bowel disease. So quickly, just to highlight, Crohn's disease, mouth to anus, ulcerative colitis, restricted to the colon, and I'll leave it at that. And then we have this nice little illustration here, which has already been highlighted, that we have multiple factors that result in the presentation of or the development of this condition. So this part, I really want to spend a few minutes looking at, not so much for the symptoms themselves, but I want us to really focus in on how these symptoms are important in day-to-day living and how they impact our day-to-day living. So when we look at them closely, these are symptoms that are oftentimes private, yet they impact us significantly when we see them. When we see diarrhea as being one of the more common symptoms associated, particularly with ulcerative colitis, that's a condition, that's a symptom that we generally don't talk publicly about. When we see rectal bleeding, seeing that being present, that's not something we really discuss a whole lot of. And so these are important things when we talk about the quality of life that it can be affected when you have inflammatory bowel disease. So really focusing in on what do these symptoms mean to me and how important is it for me to feel well, be well. All right, and so I walk through this. And so when we present with these symptoms and then we subsequently in the gastroenterologist's office, and we have these blood tests, stool tests, radiologic evaluations from CT scans and MRs, and back in the old days, these upper GI small bowel follow-throughs that we do. And then we subsequently end with endoscopy, and the culmination of those tests ends up yielding the diagnosis of inflammatory bowel disease, either Crohn's disease or ulcerative colitis. And so I wanted to show an actual picture endoscopically of what we see. And these pictures are likely not unfamiliar to you. And so in the left panel, we see the picture of Crohn's disease, where we see these long linear ulcers. And this is the exudated appearance. We see the change in the architecture from being a smooth pink-like area to having this really distorted diameter of the lumen. And then in the right panel, resembles just red, beefy red inflammation that we typically can see with ulcerative colitis. And so when we get these findings and we're told after endoscopy that this is going to be our diagnosis, we go to the next step of, well, let's talk about what does this mean to me? What are we talking about? And we want to have this conversation very candidly and open. And this is where I think a lot of the compliance issues begin, is we don't initiate this very frank discussion. And sometimes it's on The patient side sometimes is on the provider side, but that communication component is critical. And so what questions should we go into the meeting with our provider thinking about? The first thing that I would consider is, what are my goals for my health now that I have this condition? My goals for my health. Those are important questions. The next question you may want to ask is, what are my provider's goals for my health? Within that, you want to figure out in that discussion, do they match? My goals for my health, provider's goals for my health. These are important things as we start navigating the stream of healthcare in IBD. So let's talk a little bit about patient goals. Well, what should you think about? What does the average patient want when they have this diagnosis? Many times they've been ill for a while. This is typically not diagnosed the first couple of weeks you have it. So you've been sick for a while, and now you have to reflect on, what am I looking for? I want to be symptom-free. Most patients, the main thing they want to get back is life as usual. I want to be disease-free, would be nice, but the beginning of it is, give me restoration of my health. Give me symptom-free status again so that I can do my normal day-to-day activities, so I can enjoy life again. And all of that plays into the quality of life. I don't want to limp around having 5 to 6 bowel movements a day, if that was what I'm able to get down to. I really want to get back to that normal pattern of living, no pain, no loose stools, no bloody stools. I want the quality of life that I was accustomed to before I became ill. No anemia, no fatigue. If we're looking at the pediatric population, and as we saw in Dr. Adamson's presentation, 15 to 35 being that peak age, growth and development. Most kids don't like the idea of slowing down their growth. Even if you're male or female, that's not something that we're looking forward to having. And so that becomes a big push for us. And it's actually one of the conversations that we have when we talk about escalating therapy is, have we achieved appropriate growth and development? So now let's compare that to the provider's clinical goals. What is the provider looking at? Remission, disease maintenance. And so we look at these things and it sounds almost like we're speaking a different language. Providers talking about remission, you're talking about, well, what exactly does that mean to you? Back in the day when I trained, we used symptoms as the guide to remission. And back then, we saw that as our objective. And now, with the advent of better medications, better monitoring strategies, our objective now is more than what we call clinical remission or symptom-free status. We're actually looking forward to pushing that remission till we see the health of the intestines being impacted by it. And we look at disease maintenance in the same way that you look at your quality of life and being symptom-free, as we want to achieve remission, clinical and healthy intestines and appearance, but we also want to maintain that status once we've achieved it. We don't want to see fluctuations that translates into poor quality of life. So different languages, same objectives. And we have to learn as providers to make that clear to you that we're speaking the same language and we have the same goals. So why should we treat patients with IBD? Just to emphasize again, we want to resolve those symptoms. We want to improve quality of life. We want to induce remission. We want to see mucosal healing. In other words, when I do endoscopy, I see a healthy appearing intestines. I can't tell the difference between a normal healthy intestine or someone who has a diagnosis of an inflammatory bowel disease. And if we really are successful, we'd like to see deep remission In other words, when I take a biopsy, I still can't see any signs of disease activity. So those are the objectives. And that's what it translates into. We'd like to see those things translating into symptom-free, great quality of life for the patient. That's what our objective has to be. So how do we evaluate these treatments and the responses? So we listen to your symptoms. So the symptom report, but we have all these fancy measures that we can use, these scoring indexes that we use in clinical trials quite a bit. So those are ways that we can do it. But we also use objective measures. Now, why did I put this on here? Simple. What I tell patients is, I want you to feel good, look good on the outside, but I also want to know if you look as good on the inside. So I'd like to achieve normal, healthy GI tract so that you look good inside and out. So these are the measures that we use to detect those changes. I'll pause here and deviate just a little bit. So when I have patients who are challenged by the questions that I'm asking them to advance therapy or to do further testing when they feel well, what my objective is to identify any signs of disease activity that may be starting to progress, so that we can intervene before you ever experience it. What our real objective is once you present it, let that be the sickest you will ever, because now we've developed a strategy to monitor you so that we can pick up on changes in response before you ever experience anything as poorly as you did before when you were diagnosed. So why does medicine fail? Why do medicines fail? So some of the reasons medicines fail is the best target we didn't identify. So in other words, we can look at all of these great medicines out there. And when we look at them, it may simply be that we're doing the best we can. We hadn't learned everything about IBD, but we hadn't identified the target that's driving your inflammation. And so there are some times that we have to reset and look at what are we using and how is it affecting you. But these are conversations that we should have with you as well. And I'll talk a little bit more about that. So other reasons that medicines fail you is that you develop reactions to the medicine. And I always say that we don't want you on a medicine that makes you feel worse than you felt before you took the medicine. If that's how you feel, the chances are that's not the best medication for you. And we need to look a little bit deeper to see if there's something that we can use that can better impact your condition. Loss responsive medicines. This can be from a host of reasons, and most people these days are familiar with infliximab and how some people can develop antibodies to that medication. And so it's important that we monitor the drug levels of the medications, but we also important that we emphasize how critical it is to be timely with the medications, because when we're feeling well, the hardest thing to do is to convince people to continue to take a medicine when they feel awesome. I always use cholesterol as a great example. No one knows what high cholesterol feels like. It feels like nothing until you have a heart attack. So when you look at, well, why do you take those medicines? It's a preventive measure to try to keep things at bay. So once we get you well, we want to keep you well. And some of the response can be that if we see the waning effect and we're not able to intervene by adjusting doses, that can cause loss response. And there's where we lead into is medication non-adherence. Oftentimes, because we don't communicate with our providers well, or let's reverse that, because rather than saying you don't communicate well, let's say we don't communicate well with you. Our issue sometimes is your appointments may be only 15 minutes. And if we're running behind and rushing, oftentimes we'll come in and we get those few symptoms, how many bowel movements, how's your energy, belly pain, and all those things. And if it all sounds good to the ear, we're rolling on to the next thing, and we don't talk to you or give you that opportunity to talk about, hey, I'd like to see about stretching this interval out some because I feel great all the time. It's not wise to simply start stretching the interval out on your own because you feel well. There's a lot more that goes into, are you at a place where you won't lose response because we let the medicine run to a too low a level, that you want to have that conversation so that that's not a part of the issue. So medication non-adherence is a key to losing response or failing to respond. Now, I'm going to back up and talk one more thing about medication non-adherence. One thing that I experience is with my mother, and she's from that era that a doctor prescribes a medicine to her and it's an automatic, I'm not taking it. It doesn't matter what it was for. And I always ask, well, why did you go? Why did you go to see the person if you've already decided you're not going to take the medicine? So there are some attitudes in that vein as well, that if we don't develop the relationships, we will be challenged at getting patients to take those medicines. So now I'll jump over to withdrawal of medications. With the medicines that we use now, there's oftentimes fears and concerns that go along with what we're using, and especially the length of time that some people are having to take these medicines, that withdrawal of medications becomes a part of a concern, but it's not always a concern that's shared with the provider who's caring for you. Sometimes the decision is made independently, that you decide, I've been feeling awesome for so long that I don't need to take any more medicines. I'm good. And we'll wait to see what happens. So withdrawal of medications can sometimes be looked at. It's not something that we recommend because this is a chronic condition. We don't have a cure for this yet, but with organizations like the CCF, we're going to see changes in that and hopefully a cure soon. But when we start looking at this condition and withdrawing medicines, it's always there. That inflammation is always there. Sometimes it becomes quiescent. And so there are opportunities to look at refining the treatment, but we have to be careful that these are conversations that are had with providers so that we can have the best chance of reducing disease exacerbations by avoiding making those rash decisions. I've had many conversations. If you don't have or weren't diagnosed when you were in the pediatric world, or if you have a child who has inflammatory bowel disease, these are conversations that come up quite a bit. And sometimes people actually don't do what I ask them to do. And so sometimes we have to come up with a strategy. So whenever someone asks me about withdrawing medicines, the first thing that I suggest is that they determine what level of remission are you. And so I'm going to step through some simple ways to look at it. If you are in clinical remission, that's saying you're symptom-free. If you're in biochemical remission, that says all your labs are normal. If you're in radiographic remission, particularly with Crohn's disease, that means your intestines look as healthy as anyone's intestines. There are no changes to suggest you have anything. And if you're in endoscopic remission, that means when we perform endoscopy, your mucosa, your lining looks healthy. And lastly, if you're in deep remission, we take all those that I've mentioned, add in microscopically, there are no changes or inflammation in the GI tract. If you've achieved that level of remission, then your best chance of having a longer period where you don't have an exacerbation or a flare-up is in deep remission. If you go off of medicines and you still have active disease, your chances of having recurrence or flare-up are much higher and are likely to happen much sooner. Plus, the opportunity at the medication that you are on is at risk of no longer being an effective medication for you down the road. So there's a lot of discussion that should take place if you're thinking along the lines of withdrawing medication. Have that conversation with your provider. I always like to present something that's fun as well. And so with this, I'm going to tell you what we see in terms of different patient types, and not to be comical, but to suggest that with each patient type, we have to understand as providers what the conversation needs to be. So the first patient type is the gambler. This is that person who is aware of all the benefits of the medication, but will take a chance that they won't experience any issues if they don't take them or if they miss them. So they're gambling on, I'll still have something that'll work and will make me well. All right, the next type of patient is the teacher's pet. These are the ones who actually do everything you ask them to do. They're the seemingly perfect patient, but you have to be careful with them because these are also the people pleasers, that they will say whatever they think the provider wants to hear to make them happy with them. So they'll do everything, and they are often the compliant patient, but sometimes they're just people pleasing. All right, the next type is the distracted patient. Oh, I'm so busy doing so many things. I'm in school, I'm working, I'm doing all these things, and I just forget, oh, that appointment was, and I failed to go to that appointment. So those are those patients that are so distracted and they have not prioritized their health as being important, that they won't miss appointments, won't miss medications. And then the last type is the rebel. These are those patients who've decided that whatever the doctor is asking them to do, they're doing the opposite. I'm going to go, and I'm just going to throw this out just because, I saw someone ask a question about alternative and complementary treatments. And so many times people will divert to those. And let me put in my disclaimer, I am not anti-complementary treatments, but I just emphasize the fact that sometimes we're looking for anything opposite of the things that the providers are doing. All right. So the next thing that I like to do is talk about strategies to improve medication adherence. And so some of this conversation is trying to teach you how to have an impactful appointment. One of the most difficult things I think patients have is that they don't always come prepared for the appointment, prepared so that they can get all the information that they need to make a decision on their care. And so this is a critical strategy, because what you're looking at when you're seeing someone is you have about 15 minutes to actually see your physician, 15 to 20 minutes if you're an established patient. And so if you come in and you're not prepared and you're thinking of questions on the spot, oftentimes you may lose the ability to identify all your concerns in a timely fashion so that they can be effectively addressed. So prepare for your appointments. These are important. These are all about your health. But physicians need to do it as well. Physicians, nurse practitioners, we need to open our minds up to think about what are my patients' goals for their health. Build that relationship, because one of the reasons that medications fail and compliance is affected is we don't have a connection with our provider. We don't trust them. So communicate with the patients, obtain commitment to the therapeutic objectives. In other words, when you have the discussion, make the agreement on whether or not you can do or will do that treatment so that we can assess it. We need to look at the whole person, the emotional and psychological aspects, as well as the physical. And then always, we as providers have to educate. So if you have questions about certain things, alternative complementary treatments, send those questions in advance so that if your provider is not well read on those topics, that they'll have an opportunity to get evidence to support or refute the treatment that you may be asking about. Now, goal-oriented care, and I'm going to wrap up really quickly. Open, honest communication is key. Provide accurate, concise information about your health. Ask the right questions. Ask tough questions. If you're thinking about stopping medicines, don't not talk about it, because your provider may be able to sway you to continue taking the medicines because they can demonstrate the level of your disease status. How well controlled are you? When you can expect to feel better. Whenever you start a new medicine, I try to do this all the time with my patients, is tell them, when do I expect the medicine to take effect? When do I expect to see the response? Because you don't want to just take a medicine and not know when the impact is supposed to be there. And it also helps you to not misjudge when the impact should take place. That if you don't know, you may actually say, well, I've taken 2 doses of that and it didn't work, when the goal may have been you need to be on it 6 doses, whatever the case is. So establish clear goals with your provider, determine timelines. When should I come back? Do you want close follow-up? I want to see you until I see you doing well before I start stretching appointments out. Adhere to the plan, establish the plan, agree to the plan, but adhere to it. And it includes more than just the medications. It also includes being on time for your monitoring, being on time for your labs, doing the stool test, the x-rays, all those things, because it's all about optimizing your care to get the best health outcome. Last slide. IBD is chronic, long-term condition. We want to achieve and maintain remission. Symptom resolution is only one of the goals. Remember those other levels that we talked about. Medication compliance is essential if we hope to achieve those treatment goals. Compliance with those appointments help to reinforce those things. They're our checkpoints. So what the goal of care is to take you from here, where we see architectural distortion, where we see beefy red intestines, to a place that looks more like this, where the lining of the intestine is fully healthy. So I'll stop there.
Thank you. Thank you, Dr. Moulton. Thank you for that very dynamic presentation. We now have our third and final speaker for this evening. She's Dr. Kanika McNeil. Dr. McNeil is the Senior Director of Education and Diversity and Engagement for the Crohn's and Colitis Foundation, in which she focuses on engaging and creating culturally relevant IBD education and resources for diverse communities. She will provide you with an overview of some very important Crohn's and Colitis Foundation resources. And stay tuned, because she's also going to follow with an exciting raffle and even more information. Thank you, Dr. McNeil.
Thank you so much, Dr. Lockett. So let me go ahead and share my screen. Okay, so I know we are getting close to the end of time, so I will be pretty brief because we want to make sure that we get to some of those questions in our question and answer session and hear from our wonderful speakers. But I did just want to share some brief information about the Crohn's and Colitis Foundation and a lot of the resources that we currently have available to you as patients. Okay, so many of you might be familiar with some of these resources already. If so, this is really a refresher for you. I know it's always nice to just kind of learn a little bit more about some of the resources, and some of you might not know anything about our resources, so hopefully this is some great information for you to take away. So our IBD Help Center is definitely one of our major resources that we have at the foundation. This resource is basically for anyone that has any questions about IBD. We have trained specialists that are available to provide information, guidance, support, referrals to our support groups, any education programs. And the benefit is that we actually have 170 different languages. So feel free to utilize this resource anytime that you might have any questions. And so we can basically guide you in the right direction and be able to provide you with some resources that we have, such as our brochures and fact sheets, which I'll talk about a little bit more. You'll see here that you can contact the IBD Help Center a variety of ways through our by phone, email, and also we have live chat that's available. We have several educational materials that are currently available to patients as well as caregivers. This is just a few that are listed. And when I say literally just a few, we have so many resources, so many materials and educational brochures. So I encourage you to definitely go to our website. You will see here below, it's Crohn'sColitisFoundation.org. And then you can go to info and then all brochures. And you'll be able to download any of the brochures that we have. We also have some available in Spanish as well. And then to piggyback off that, we have a lot of educational materials that are available for our pediatric patients, as well as parents and caregivers of those patients. So a guide for teachers, for example, we know many kids, a lot of times their teachers might not understand what Crohn's disease or colitis, what they are. And so with that being said, this is a great tool for them to utilize. We have our teen website. Our teen website is really helpful and extremely helpful to any teen that is currently living with Crohn's disease or colitis. It's a great opportunity for them to start to really learn about their disease and how to manage and to really build skills around nutrition and diet, dealing with dating, stress, anything related to really teens. And so you can go to www.justlikemeibd.org. We also have something that is similar to our teen website, but this is our college website, and this is for Campus Connection. And so this is a great opportunity for college students to really go and to continue to learn about their journey if they were recently diagnosed or if they were diagnosed in previous years. But this is an opportunity for them to find a doctor in their local area, for example, if they're going away to college, and then also really just to find out tips on how to share their diagnosis with friends. We know that a lot of times can be a difficult conversation to have, but there's a lot of resources here for college students to be able to really manage their disease. Campo ACE is one of our favorite programs at the foundation. And so this is a great tool for and great resource for really kids living with IBD between the ages of 7 and 17. And so it is a co-ed residential summer camp. We're really excited to say that this year we are back in person. So awesome because we have been virtual the past couple of years due to the pandemic. So really excited about that. If you have someone, a child that's interested in learning more about Campo ACEs, I encourage you to go to our website, and then applications are currently available. And we do also have a virtual option as well for those that aren't able to actually attend camp in person this year. And then this is a great resource as well. Anytime you're want to learn more about your journey as it relates to being a patient in specific areas, you can go to our website and watch videos, find resources on some of these topics. So includes nutrition, financial and insurance information, mental health, as well as surgery. In our clinical trials community, this is really important because, we're we're trying to continue to help patients and be able to find additional medications that can treat them. And so we actually have a clinical trials community in which you can actually get information on research that's actually written by researchers and experts. And it's an opportunity for you to really engage with patients and caregivers who are willing to really share their story about how they've been a part of a clinical trial. And so if you're interested in learning more about clinical trials, you can definitely visit our website here. So I think Dr. Adamson mentioned specifically about our support groups. We have several support groups, live support groups, and we also have some virtual support groups. And I will tell you, we're actually working on starting 2 new support groups, one for the Black African American community and one specifically for the Hispanic Latino community. We're currently looking for support group facilitators. And so I encourage you to definitely, this is an opportunity for you to connect with other people that are affected by IBD. You can find a local support group in your area, or like I said, you can join virtually a local support group. And so you can go to our website to see what support groups are available to you. Power of 2. This is a great way for you to connect with others that actually have IBD, or if you're a caregiver, a mother, father, a spouse, for example, and you're looking for that one-on-one support, this is the place to go. So we have our Power of 2 program. It's been around for a little while, and it's an opportunity for you to really connect and to share any challenges that you might be facing and to really get support from that individual. And so you can share similar experiences through calls, messages, community posts, and also we have our own app that can match you. So that is actually a really great tool and definitely a good resource that we've actually recently launched our app. And then our Crohn's and colitis community. This is similar to our teen website as well as our college website, but this is specifically for adults. And this is a great way for patients, caregivers to log on to join discussion boards about specific topics related to Crohn's disease and or colitis, to share your personal experiences, but also to hear personal experiences. A lot of times it is helpful to hear from others, and then also to ask any questions that you might have to our panel of experts. And last, I think this is, if not close to the last slide, we always encourage you to participate in research if this is something you're interested in. So this is an opportunity where you can join Ibd Partners, which is, we have about 15,000 adults enrolled and over 900 pediatric patients enrolled. And this really helps us to be able to find cures for Crohn's disease and colitis. So if you're interested, you can always go to our website and find out more information here as well. And last but not least, we encourage you to definitely be an advocate. So we have our Director of Advocacy in our advocacy department. We have Day on the Hill, for example, that's coming up. And so this is a great way for us to go to our legislators and advocate on behalf of patients and caregivers that are currently impacted by IBD and to really be able to share our stories. And so if you're interested in learning more about how to be an advocate and to share your story, you can go to our website and you can share information there or get information there. And just a few upcoming events that we have. You'll see our MyIBD Learning webinar series that is here. We have one specifically for tips for teens and college students on April 26th. And you'll see several regional programs that we have coming up in there in person, which is awesome. So I encourage you, if you're in these areas, to definitely go to our website. You can register. And then next week, we actually have a Facebook Live chat for the Hispanic Latino community that was specifically focused on complementary and alternative medicine. So that concludes my presentation. And so again, I wanted to be pretty brief. If you have any specific questions, you can definitely feel free to, just put them in the chat. So at this time, I would like us to go ahead and transition to our question and answer session. And so I would like to invite Dr. Adamson and Dr. Moulton back to answer any questions from the audience. So feel free to turn on your cameras. And we do have a few questions that have come in. And so I will go ahead and read them, and we'll go from there. Okay, so the first question is, I currently take 2 medications for my UC, in which I am in remission and currently exploring natural treatment options through a neuropathy doctor. What would you suggest for natural treatment options? Any suggestions for natural treatment? And I will ask if you, we want to keep the questions pretty general. I know our medical professionals don't have your history, which we completely understand. So they will try to answer your questions to the best of their ability. But we also always encourage you to talk to your local gastroenterologist because they have your history. But any suggestions just for natural treatment options as it relates to complementary and alternative medicine?
Well, I guess I'll start. So the first thing that I would look at is, what do you mean by clinical remission? I outlined a few things in my presentation, and so it really would depend on where you are in remission. There are some alternative things out there that can be used that have been shown, like curcumin is one of the first that comes to mind in terms of anti-inflammatories. But, what I typically suggest is really looking at what type of remission you're in. And I purposely put that in to say, if you're just talking about symptom-free, because of the effects that a smoldering inflammatory process can have in UC, and it can increase the risk of colon cancer, colorectal cancer, I'm hesitant to say, hey, try this medication, because that may be steering you in the wrong direction. But there are a few, and I'd say curcumin would be one of the first that I think has easier access to. And so that's where I would start, but I'd look into your level of remission first.
I realized I was muted. Okay, great. Thank you, Dr. Moulton. Okay, so the next question that we have here, is there any medication that you would suggest that can help with the pain during a flare? So, I know Dr. Adamson, for example, with certain medications you suggested not for patients, that patients should not take. Is there anything that patients can do when they're having any pain related to a flare?
So generally, I would recommend acetaminophen can be taken for pain for patients when you have a flare or anything like that. I think there was another question in the chat related to what did I mention not to take, and that was specifically NSAIDs. So things like ibuprofen, Aleve, goody powder, which patients tend to take. And also trying to limit or avoid narcotics, because that can also lead to other complications with constipation and things like that down the line.
Okay, great. Thank you, Dr. Adamson.
Can I add one thing to that? So, so I want to raise the bar a little bit. I don't like flares. I don't find them acceptable. And so, and sometimes we can't control it. So I'm not naive when it comes to that. But what I try to encourage patients to do is to be much more selfish and much more insistent on better health. So just accepting a flare is not acceptable. If you're the right patient, sometimes, and Dr. Adamson, you can also give some feedback on this, the antispasmodics can be of benefit depending on what you're dealing with. But we're very careful when you're flaring, because unfortunately some of the symptoms you have are the best indicators for us in terms of how significant the disease is, but antispasmodics sometimes are used, such as dicyclamine or hyoscyamine, but in very select cases. So we try to avoid medicating for pain and try to treat to the target of getting you better.
Mm-hmm. Great, thank you so much for that addition, Dr. Moulton. I do see a question here in which someone asks, what resource does the foundation have to explain to IBD, explain IBD to family and spouses? I would say that, really honestly, any of our brochures, I think though that's really helpful to be able to share. I would say our education programs, I know, several family members, spouses attend programs to really learn more about IBD. And then also support groups. Many of our support groups are definitely open, not just to patients, but also to our caregivers. So, and when I say caregivers, spouses, family members, friends, so anyone, parents. So that is available to our families as well as spouses. So hopefully that answered your question. I do see another question here that says, what does the patient have to initiate the remission testing? If so, at what point should that happen after a year?
Since I ran my mouth on that, I'll give you a response. So the way we approach treatment in inflammatory bowel disease has changed a lot. Mm-hmm. And so when we start you on a medicine, there should already be a plan. So much of it has to do with how invested into the IBD community is the person that's providing the care. Because nowadays, when we start a medication, we have a time point that we're going to treat and we're going to test. Oftentimes, it's going to be even during the early phases of your treatment. So many of the newer medicines have these two phases, the induction phase, which we are testing during the induction phase. And then there are time points when we transition to the maintenance phase. So that should be initiated by the provider. But even if you're on a mesalamine type medication and you've been well controlled, if you have UC, you can even initiate, for me, I don't mind, initiate some testing to see, particularly with UC, they're great stool markers that gives you indications of whether or not there's still inflammation happening in your intestines. And so most doctors don't mind writing an order to say, yes, you can check your stool, but you want to be prepared to, what am I going to do with that test? Okay, but I think that's a great question, and that's the motivation you should have is, if you're going to start this new medicine, when are we going to test it? When are we going to know it works? And make sure that they give you those timelines. I do it for my patients all the time. I'm going to check labs here and here. And if it's not working by this time point, then we're starting to think this medicine has failed you.
Mm-hmm. Really great points. Great. Thank you, Dr. Moulton. So Dr. Adamson, someone mentioned that they wanted a little bit more clarity on what medications they should not take. So do you mind repeating that information? I know you said Tylenol, for example, is good, but what medications should IBD patients avoid?
So NSAIDs like ibuprofen, Aleve, Goody powder, things in that family.
Okay, great. Thank you, Dr. Adamson. And then we have, like I said, just a few more questions. Actually, I think 2 more questions. Someone is asking their childbearing age, and they want to know, are there any effects for taking Remicade on having children? Any studies or anything like that that you can share related to that?
Okay. So, Dr. Adamson, you want to start, and I'll pick up after you.
Sure. I guess Remicade is actually a safe drug for someone to continue, even during pregnancy, as I had mentioned earlier on. And it can also be safely continued during breastfeeding as well, too. And I know you could probably have some hesitations, but I guess the biggest thing you should always keep in mind that even in childbearing age, you want to make sure that your IBD is very well controlled before you become pregnant. But with any medication that you're starting, it's definitely important for you to have an open discussion with your provider as well and express your concerns so that they're aware of that moving forward in your care. But I have had patients on Remicade and have had no problems as far as even during their pregnancy.
Yeah, I'd emphasize that being healthy, having good disease control actually bodes much better for your fertility than having disease activity. So infliximab, achieving the goal of remission is a much more optimum treatment than trying to wean off to get pregnant. You'll probably have less success by doing that.
Great points. Thank you very much. And our final question that we have for this evening, what are the most beneficial ways of decreasing the likelihood of surgery for IBD?
Well, I'll jump on this. So preventing surgery is all about what I talked about, which is coming up with a good, strong care plan and monitoring strategy. One of the biggest mistakes we used to make, and this dates me because I was pre-Remicade as a trainee. So one of the biggest mistakes that I think we make is we settle in on feeling better and not going the extra step to see did the medication achieve what we set out to achieve, and that is restoration of intestinal health. So it's usually when you settle in on, I'm just going to do this and don't check. So I tell even patients who choose to not take standard treatments and use alternative treatments that you should go under the same rigors that we would put you on if we're prescribing a medication to you to ensure that you have the best outcome. So much of it is having a good strategy, taking the medicine, making sure that your provider is achieving the drug levels that we need to achieve, and then having that checkpoint to say, am I healing inside and out, and not just focusing on symptom recovery.
Great. Thank you, Dr. Moulton. So one final question. Someone did ask, is it safe to take Remicade and azathioprine together? And I know you would have to look at the patient, but do you know if that's something that some patients have been on together?
Go ahead, Dr. Adamson, if you would like to start.
Sure, I guess that is safe for you to take both of the medications together. If you particularly have concerns about each, because of course every medication does have associated side effects. So I can understand someone being concerned about having dual medications, but it would be safe for you to take both medications if it was recommended by your provider and it actually leads to remission of your IBD.
So the component that, I think you may be alluding to is the hepatosplenic lymphomas associated with combination therapy, particularly in young males, so adolescent and young adult males. And so I would tell you what I have seen in the pediatric community is most pediatric gastroenterologists who care for IBD patients generally don't prescribe that combination in boys. I think most have moved away from using that combination in boys, but appears to be safe and effective in girls. And so we are aware that we see those associations. And so I would say that, you know, in most of the meetings that I've been in, most don't use them. And we're finding combination therapy with methotrexate in that population when needed has demonstrated some great benefit as well.
Great. That's really helpful information. Well, I think those are all the questions that we have. Thank you so much to our two speakers. And
no one asked if I tied my tie or not. I thought that would be one of the, you know, I spent all of this time tying this tie.
It looks fantastic, Dr. Moulton. Well, people are saying thank you very much in the chat. And so before we close, I'm going to be mentioned, we will be doing a raffle. So we're going to select 3 names. So while we do that, we're going to put a evaluation in the chat. So please, if you could fill it out, it's a brief evaluation to really you know, give your feedback on this program. And we really utilize this as a way to determine how we want to shape our future programs and develop our future programs as it relates to topics. Timing, all of that great stuff. So feel free to complete that. And it is available in the chat to you. So just click on that link and it should pop up on your screen. And it is a brief, very brief survey. Okay, so selecting the names, drum roll, so we have Kim Beasley. So Kim, congratulations. And so all of the winners will actually receive a gift card in your email. So I hope your email is correct, but you will be receiving the gift card, an electronic gift card. Okay, the next person that we have here is Stacy Elder. Congratulations, Stacy. And then the last person that we have is Audrey Savage. Congratulations, Audrey. Okay, so as I mentioned, you will be receiving your gift cards in electronically via email. So feel free to check that by the end of, what's today? Tuesday. So I would say in the next couple of days, you will be receiving it. Okay. And if you do not have your correct email address, you can actually just email myself or my colleague Arushi. And you can just let us know what your correct email address is. And if you don't receive it by Friday, please check your spam because it most likely will be in there. Okay, so again, the chat, look in the chat, you have your evaluation, feel free to complete that. And so that pretty much concludes our program this evening. I would like to thank our speakers, Dr. Adamson and Dr. Moulton and Dr. Lockett, who actually was the moderator for the beginning of the program. Thank you so much for providing us with helpful information about IBD. Also a special thank you to Genentech for supporting tonight's program. And thank you to all of our attendees for joining the webinar tonight. If you have questions that were not answered, I encourage you to definitely visit our website, the Crohn's and Colitis, www.crohnscolitisfoundation.org. You can also contact our Ibd Help Center at 888-694-8872, or you can email at info@crohnscolitisfoundation.org. So thank you so much again for joining us tonight. We look forward to seeing you on future programs. Please stay safe and healthy and have a great evening. Thank you.